Hello everyone. Trauma FCPS ফাইনাল পরীক্ষার জন্য বরাবরই খুবই ইম্পর্টেন্ট একটা টপিক। পরীক্ষা পদ্ধতিতে পরিবর্তন আসার আগে যে কোনো একটা পেপারে ট্রমা থেকে অ্যাকচুয়ালি একটা বড় লং কোয়েশ্চেন থাকতোই। পরিবর্তিত পরীক্ষা পদ্ধতিতেও কিন্তু যে কোনো কোয়েশ্চনে লং কোয়েশ্চেন হোক বা শর্ট কোয়েশ্চেন যাই আসুক, ট্রমা থেকে কোয়েশ্চেন আসার চান্স খুবই বেশি। ইভেন যে ইন্টারেক্টিভ ওরাল এক্সামিনেশনেও কিন্তু ইমার্জেন্সি যে দুইটা স্টেম থাকে সেখান থেকে একটা ট্রমা হিসেবে আসার চান্স একটু বেশি। এবং গত জানুয়ারি 2021-এর যে পরীক্ষাটা হলো সেখানেও কিন্তু ট্রমাটিক ব্রেন ইঞ্জুরি নিয়ে একটা স্টেম ছিল। সো ট্রমা আমরা সবাই খুব প্রচুর টাইম দিই, অনেক পড়ালেখা করি ট্রমা নিয়ে, এবং এটা আসলে দেওয়া উচিত, কারণ দিস ইজ ভেরি ইম্পর্টেন্ট। সো লেটস স্টার্ট আওয়ার জার্নি উইথ ইমার্জেন্সি, and that is trauma. So the question can be of hemorrhagic shock. Okay. The scenario may be a 25 years old man presented to emergency room with history of RTA 5 hours back. He was in back seat of a CNG. He complained of pain in abdomen and inability to walk. He was confused but cooperative. Pallor, dehydration was noted. His pulse was 110 per minute. Blood pressure 70/40 of mercury. Respiratory rate 26 per minute. His left leg was cold, mottled, and pulseless. Pelvis was tender on palpation, and pelvic X-ray shows widening and displacement of symphysis pubis. So, আমরা জানি যে the question খুব শর্ট হতে পারে, আবার একটা সিনারিও অনেক বড় হতে পারে। এই সিনারিওটা অনেক বড় করে দেয়া। সো এখান থেকে কিন্তু অ্যান্সার যদি থাকে, রিটেনের কথা বলছি কিন্তু আমি। সো এখানে অ্যান্সারগুলো যদি থাকে, অ্যান্সার থাকবে রিটেনের ক্ষেত্রে 1 অথবা 2 মার্ক। আবার এটাই কিন্তু আমাদের ইন্টারেক্টিভ ওয়াল সেশনেও আসতে পারে। সো এই কোয়েশ্চেনটা যখন আমাদেরকে সেট আপ করা হবে, তো আমার কোয়েশ্চেনে যাওয়ার আগে আমি একটু ক্লারিফাই করে নিতে চাই যে এই কোয়েশ্চেন থাকলে আমাদের যে হেমোরেজিক শকের যে ক্লাসিফিকেশনটা, we have to mention this. So first of all, that is classified 1, 2, 3, 4, and that is classified according to blood loss, pulse, blood pressure, respiratory rate, and mental status also. If the blood loss is less than 750 ml or less than 15% total blood volume, his pulse rate is less than 100, blood pressure is normal, respiratory rate is normal, and mental status is slightly anxious, then it will be class 1. In class 2, the pulse rate will increase. It will be between 100 to 120, and the blood pressure will be normal. And in class 3, at that class, patient blood pressure will decrease. And in case of class 4, the loss will be more than 2 liter or more than 40% of the blood volume. And here blood pressure, respiratory rate, so everything will be increased, and patient will be confused and he will be lethargic. So keep this in mind. You will be then the question may be the 5 points in history, like mention 5 points you will ask to take history. So in traumatic cases, first of all, every case we have to know the mechanism of injury, whether it is high velocity or low velocity. Okay, and they mentioned that what are the situation but condition of the patient. Who was he a bystander, or he was front seat, head-on collision. So impact of and injury is very important here. And you have to ask about that patient attendant and that what was the condition of the patient prior to injury. Was he intoxicated, or he may be having some other comorbidities? That's why he may get fell and get injured. So we have to ask about the condition of the patient prior to injury and condition of the patient immediately following injury. You know, in traumatic brain injury, patient immediately loses his unconscious, then he regain, and later on he again get unconscious. So this is also important. And in that particular scenario, there maybe you have to ask about periurethral or perirectal bleeding, and we have to mention about duration of the event. So these are the common questions which will be asked in every scenario of trauma. Then that question asker may ask, the sir, your teacher may ask that what mention 5 relevant examination you will do. So in trauma, this is very easy. We can go for C, A, B, C, D, E. C for continuous exsanguinating hemorrhage. We will look for an external hemorrhage. Then A for airway and cervical spine, obviously. B for breathing, C for circulation, D for deformity, and E for exposure and environment control. So that will conclude. But in secondary survey, you have to mention, as that case is indicating towards injury to pelvis as well as injury to abdomen also. Okay, and so we have to look that particular part specifically. Like we have to palpate and compress the pelvic brim from SI joint to pubic tubercle. Okay, so pubic symphysis, and we have to inspect the skin of the groin, perineum, and sacral area. Okay, so we look for the peripheral pulsation, as we mentioned that the left leg is mottled, pulseless. Okay, we have to look for urethral metasplenary blood. Then we have to do digital rectal examination, and it is high riding prostate. There is a common question that how will differentiate and rupture of the bulbar urethra with membranous urethra, and that is done by that digital rectal examination. In bulbar urethra rupture, which occur following fall-stud injury, the prostate will be normal in sight. But in case of membranous urethra, which occur following RTA or trauma, in that cases, we will look at the high riding prostate. That prostate will not be palpable by DRE. And that indicate the complete urethral avulsion. We have to look for neurological examination, and we have to anal wink, femoral sciatic nerve examination. Then we will look for the general examination, the pulse, blood pressure that was mentioned in that particular scenario. And we have to mention the urine output and anemia. So that is, and in 5 minute examination, then you can, if you have got time, then you will look that, sir, I will, as a trauma case, I will go for C, A, B, C, D, E. Then in secondary survey, I will look for that things. And in general, I look for that things. So you can ask, you can say like this also. Mention 4 investigations. So, and in present condition, this 4, this 5, this 3, these are important in written also, and also in case of IOE. So, in that trauma case, we all know the pelvic fracture, there is XA pelvis in AP view, you have to mention. Also, chest XA PA view, and also XA the cervical spine, because these are the 3 most important things that we need to go for. And also in book, in burial now, that in trauma series, we have to go for whole body CT scan. Okay, and as well as the patient is losing blood, so we need to infuse blood. So we go for blood grouping and RS striping and other blood tests like complete blood count, look for hemoglobin, RBS, serum creatine, these things. And also as well as if as this patient is getting some abdominal distension or abdominal pain or trauma over abdomen, we need for the first or even first, okay, or ultrasound of the whole abdomen we need to go for. And to categorize the status of the shock, or we go for the arterial blood gas and serum lactate level. So these are the things that we need to do as investigation in this patient. After that, the question that teacher may ask that what is your diagnosis? At that scenario, we can go for the it is history of RTA. We can mention the age of the patient also. In foreign countries, they mention that my diagnosis is at the years male with history of RTA with pelvic fracture. It is not graded with suspected left iliac arterial injury, because this patient is left limb is mottled, pulseless. So I can suspect that the left iliac artery has been damaged. And we can mention is a class 3 because the blood pressure is also decreased, but patient is not confused. Patient is till now alert. So that's why class 3, not class 4. Okay. Now then treatment. Treatment is very easy. You know, in trauma, answering a trauma scenario is previously we need to learn the where should we stop. 25 marks question, trauma question scenario, and there are lots of options, lots of differential diagnosis, lots of things that can be injured. Okay, and we couldn't answer it in 40 minutes. It would take more than 1 hour because there are lots of injury and lots of treatment protocols. So that's why we just mentioned the important ones and the other options in a brief. Now, the treatment options in that cases. First of all, again, CABCDE, and we will examine that thing, also manage. If the patient has got bleeding, external bleeding, we will compress pressure. Okay, so packing, even we can put an artery forceps or ligate. We have to stop the bleeding. Airway, okay, we have to keep airway maintenance, breathing, circulation. So we need to go for jaw thrust, chin lift, and sucking of the external secretion if there is got anything, cricothyroidotomy, othoba thyroid, okay, tracheostomy, even endotracheal tube, nasopharyngeal area, everything, fluid, and dynamic fluid response. There are lots of options. So these are the things. So this management according to condition of the patient. Then there are some principle of managing an hemorrhagic shock. Like first of all, this is permissive hypotension. That with a dynamic fluid response we have told previously. We should avoid infusing lots of fluid. Permissive hypotension. We need to keep the patient in hypotension. Avoid use of crystal oil. Avoid. So this is it. So if a patient come with trauma and in our locality, it is very practice that give fluid, give fluid. If you don't infuse fluid, people will think that the patient is not getting a treatment. But if you infuse lots of crystalloids, you are harming the patient actually. And there is another important thing which I missed at all. This triaximic acid. The dosing schedule also 1 gram in 8 hours. Okay, so these are the principles of managing an hemorrhagic shock. Now all the specific, that means we are targeting towards that there may be pelvic fracture. So if this patient is having this pelvic fracture, we will give a compression binder, or any sheet that will be applied through pelvis and at the level of the greater trochanter. So every information is very important. And we also can use the external fixator, or even we can pack external peritoneally. So you can apply extra peritoneal packing also. And obviously, this is a multidisciplinary. This terminologies you should mention, like multidisciplinary approach, consisting of orthopedic, general surgeon, vascular, interventional radiologist. And as we have mentioned, arterial injury, for that particular cases, if interventional radiologist is available, we go for angioembolization following compression, packing, and fixation. And if there is concurrent significant amount of blood in peritoneal cavity, we will go for exploratory laparotomy after evaluation. And also in pelvic fracture, you know that urethra may get ruptured. If there is an evidence of urethral rupture, first of all, we will not catheterize the patient. So we will not catheterize the patient. Okay, so if that patient is having that particular thing, we can go for the suprapubic cystostomy. Okay, to drain the urine. If it is, or that patient may have any extra peritoneal bladder rupture or even extra intraperitoneal bladder rupture. We have to manage that things also. Though this scenario doesn't include these things, but in our time, we have to think all the particular things in a trauma case. Okay, so these are the things, specific treatment. Okay. Then rationale of use of drug or surgery. Like in that scenario, as we are asking about tranexamic acids, okay, so the indication of that thing, the doses of that thing, and contraindication of that thing, like defective color vision and active intravascular clotting, that are the contraindications of using tranexamic acid. And if the patient is suspected case of DVT or pulmonary embolism, then we have to avoid using this tranexamic acid. You may ask that, the teacher may ask that what is the role of tranexamic acid in hemorrhage? So the answer will be, we all know that this is antifibrinolytic, and this antifibrinolytic inhibits both plasminogen activator and plasmin activity, and that will prevent clot breakdown, and that will also promote new clot formation. With these things, that will arrest bleeding. So that's why that is used. Adverse drug reaction of this, that it can lead to VTE or deep vein thrombosis, pulmonary embolism. It can lead to anaphylaxis also and damages the color vision. So these are the things. Okay. After that, the next question will be the prognosis and complication related. Okay. And when I took preparation, the prognosis related questions, I tried to answer that there are some factors, the general patient related factors and the disease related factors. Patient related factors are common for all, like the more the age, the odds are the prognostic factor. Duration of anything, if the longer the duration, odds are the prognosis. If the patient is having a comorbidity, that patient will have odds of prognosis. Even regarding the injury, as this is cases, the grade we all know, in trauma, the ASD grades every kind of injury. So if the grading is more severe, the prognosis will be odds are. Site of injury, okay, site of injury. Like in case of, if the patient is having a pelvic fracture, that is closed open book fracture, prognosis will be worse. Number of injuries, okay, polytrauma, multiple trauma, in that particular cases, or multiple gut perforations, the prognosis will be worse. In case of pelvic peritonitis, if the patient is having an open wound, or if the contamination is more, okay, though that patient is more prone to develop complications. Okay, so the prognostic factors we can divide in that way, that patient related and that injury or disease related. Also the question with complications. In case of complications also, we will divide it into general complications and specific or injury related complications. General is usual, the pulmonary complications. Okay, that patient may develop atelectasis, pneumonia, ARDS. If patient is not ambulant, that patient may develop DVT or pulmonary embolism. And infection related, that may be patient may develop sepsis, even renal compromise also. And specific for that particular thing, like if that patient is having pelvic fracture. Okay, so in fracture, we all know that there is some immediate and delayed or late. Immediate, that means patient may die due to heavy bleeding. In pelvic fracture, the massive bleeding occurs. Okay, and most of the bleeding is from the veins. Okay, so patient may die of this, of the bleeding. The neurovascular structure may get injured, as well as in delayed or late, that patient may develop delayed union, non-union. These things are, so it's complication related to the fracture also. An outcome assessment, I mean, I have mentioned here only that about the shock, hemorrhagic shock related, but also outcome assessment would be categorized according to the fracture or any other injury like bladder injury, urethral injury, rectal injury. Okay, so that is also important. Basic and paramedical in shock related things, that pulse, why the pulse is increased and why blood pressure is decreased, why unit output is decreased. Everything we know that there is low perfusion. In case of low perfusion, everything shuts down. And another important is in trauma, that is ATC by acute traumatic coagulopathy. You guys all know the triad of death. In trauma, hypothermia, acidosis, and hypothermia, acidosis, that will lead to trauma in death. Yeah. So that's why in trauma case we don't need to infuse. We avoid infuse cold blood or cold water, cold saline. Try to warm this. Avoid giving crystalloid, and if you have to give this, then warm it, then give. In shock, you all know that shock is an anaerobic glycolysis, and in anaerobic conditions, lactate produced. That's why it leads to metabolic acidosis. Okay, and also these two things also impair the coagulation. So these three, coagulopathy, acidosis, and hypothermia, are interconnected and leads the traumatic patient to death. Okay, synergistically. So this is acute traumatic coagulopathy. This is very important, I think. Now there may be a future direction. What future directions regarding this management of hemorrhagic shock? We can tell that we will turn over to the fluid-less resuscitation. We are promoting that use less fluid. Someday we will describe that fluidless. So we will not use any fluid. Protective hypothermia. Hypothermia. If we decrease the temperature of the patient, metabolism or many other things will also lessen. Patient will have more time to show compensatory mechanisms. So these protective hypothermia and preserved blood products, these are the future direction, I think. So that question may also come in that scenario. This occult hypovolemia, that may be a question. Okay, occult hypovolemia bolte kiভাবে বুঝো, what, how we will assume occult hypovolemia. So increasing pallor, increasing heart rate, decreasing blood pressure, oliguria, postural hypotension with a fall of systolic blood pressure 20 mm of mercury, diastolic blood pressure 10, 20, 10, 20 is the rule. So this is occult hypovolemia, very important. And in that particular scenario, as this patient is having pelvic fracture, they may ask about the discuss sources of blood. Sources of blood. I have previously mentioned 85% arises from brain. And that patient will have rich collateral supply, especially from sacrum and posterior part of the ilium. And the pelvic bones are cancellous bone, and cancellous bone has excellent blood supply. And every year, the extraperitoneal space can accommodate more than 3 liters. There is a chimney effect mentioned in your Bayesian law, that even the patient, the blood may traverse to the chest also, this chimney effect. So it's a very massive thing. And iliac vessels. So these are the things, they are sources of bleeding here in pelvic fracture. Okay. So that is all about that first scenario. The second scenario is, I have just discussed the questions. A motorcyclist was admitted to the emergency department, having been thrown a distance of 30 feet. Okay, he was wearing a helmet and had recovered consciousness. Okay, he remained confused. Pulse 40, very low. Respiratory rate 30, increase. Blood pressure very low. And on catheter, no urine output. So we have gone for lateral cervical spine X-ray and cervical fracture C7. So they specifically mentioned about these things. So these are the things. The question may be again that mentioned 5 questions. Mentioned 5. We have mentioned that do you have any question regarding the patient's history? But teacher will ask that 5 questions or 4 questions. So what will be the questions? Again, that mechanism of injury, the high velocity, low velocity, from where he has fallen down. Condition of the patient prior to injury, I have discussed. Condition of patient immediately following injury. Complaints, what are his complaints? Lower back pain, weakness, numbness, bowel and bladder dysfunction, very important here. Or we may ask the history of headache, blurring of vision, double vision. That means we have mentioning about brain injuries, seizure fever, or nasal interaction. So these questions may be asked, and if your teacher asks to state. Okay. So what examinations you will do in that particular case again? So these C, A, B, C, D, E, and breathing pattern. The general examination, the breathing pattern. Okay. Higher the injury, more severe is the effect. If the injury is C4 and above, patient will not be able to breathe because sphenic nerve is supplied by that C5, 6 level. Because no diaphragm, no intercostal. So very important. If the patient's injury is C4 and above, patient cannot breathe. You have to intubate the patient to give some relief. And if the injury is T3 or T4 level, the diaphragm remains intact. So breathing can occur. But above T3, the breathing is purely diaphragmatic, no intercostal. So that is it. So by looking at the breathing pattern, we can assume that at what level the spine has got injured. Also, that's Horner syndrome, you guys all know, and priapism is due to vasodilation of the blood of the penis. And palpate the spine. The spine is injured, so palpate the spine. Okay, for tenderness, any deformity, any misalignment, muscle spasm. Okay, ardent intercostal disc. We have to palpate the spine, and we have to go for the neurological examination. Okay, and level of the loss level, Asia grading. So here sensory motor, this you have to grade this spine injury according to this Asia. Okay, then we have to go for DRE most, and DRE it will differentiate and complete versus incomplete spinal cord injury. And we have to need for the bulbocavernous reflex, very important. Picture is there is a picture in Balian love. And we have to look for the grade 2 movement, grade 2 flexion, very important. Okay, so these are the things we need to know for particular spinal cord injuries. Okay, because why we are assuming this? Because that patient is pulse rate is usually if the blood pressure increases but decreases, pulse rate will be increased. But in that particular case, pulse decrease as well as blood pressure decrease. So we have assumed that the patient may be having spinal cord injury. Okay. So what next question may be? What investigation we will look for? But we will ask for. So first of all, we can go for next imaging to ascertain imaging of cervical spine, even imaging of that particular region, lumbar spine, and these things. After that, we will go for MRI or CT scan. Okay, here is some description. Teacher may ask that discuss role of X-ray. Okay, so X-ray that it can provide informations early as it is easy and available. Okay, so that's why it can tell about the fractures or dislocation. The teacher can ask that compare CT scan with MRI, or in your written question may ask that compare CT scan with MRI in that particular case. Actually, CT scan, you all know that CT scan is better for bone structures. So in fracture, CT scan, 3D CT scan will provide more information. But if the soft tissues or just ligaments or the neural cord structures for that particular regions, compression, or whether there is any compression of the nerve structures, that will be ascertained by the MRI. Okay, so CT scan will provide information of the bone structures better, but neural structures injury, that will be better aligned by the MRI. So that discussion is important. You all know. Then that condition of the shocks, serum lactate or other things, and also blood grouping, complete others. You no need to describe, I think. Okay. After that, after that, that option is treatment. And as we all know that first of all, we will in trauma case, we will tell that treatment at TLS protocol. And we have to immobilize this patient first and rule out other possibilities. Okay. Then in case of transfer, we have to be very cautious. Okay. As a quadruple immobilization. Okay. So 4 people will be needed in case of transfer, spinal board. So that immobilization is very important in transfer. That can be a particular question in anywhere, written or viva also. The transfer of the spinal cord patient. Refer to level wall trauma center. This is also second. What is level wall trauma center? Minimize secondary injury in brain or spinal cord injury. Secondary injury prevention is very important. That means patient should be avoided to hypoxia or hyperkalemia. Okay, any electrolyte imbalances, any metabolic imbalances. We have to prevent these things. So that is important. AROA and other things, if the patient elation is above C5, requires intubation and ventral support. Fluid, don't overload. Okay. Sometimes we consider alpha agonist. Okay, so in that particular case, the patient is having blood pressure is low as well as the pulse rate is low. So fluid is important, but don't overload it. And as this patient, blood pressure and heart rate both are problems, so consider for dopamine or norepinephrine. Okay, dopamine or norepinephrine you have to consider. And use of methylprednisolone, that is controversial. Some says that if we can use within 8 hours of spinal cord injury, that the result is dramatic. Some others defer it. Okay. So next question, that are some theoretical description that how can we differentiate the neurological or neurogenic shock from spinal shock? Why not it is a spinal shock or neurogenic shock? So look at the things that neurogenic shock results from impairment of descending sympathetic pathways in cervical or upper thoracic cord. This results in loss of vasomotor tone loss and sympathetic innervation to heart. Loss of vasomotor tone will lead to vasodilation of the visceral and lower extremity blood vessels, and that will lead to pooling of blood and hypotension. Loss of sympathetic innervation to heart, it results in bradycardia, and it is due to unopposed vagal tone resulting from cervical spinal cord injury. So in case of spinal cord injury, there is inhibition of sympathetic nervous system, but there is preservation of the peripheral parasympathetic nervous system. So there is impact on coronary vessels like decreased SVR, decreased inotropic, and decreased preload, decreased heart rate, and low blood pressure. The question may ask that why heart rate is low. So that is the thing, that in case of this thing, in case of spinal cord injury, there is inhibition of sympathetic nervous system, but preservation of the parasympathetic nervous system. That's why heart rate lows. Heart rate also low. This sympathetic nervous system, that is alpha predominant, causes vasoconstriction, and this will release glucocorticoid Ultimately, there is increased random blood sugar. It will generate heat. Patient will have sweating, diaphoresis. Okay. And in case of neurogenic shock, the thing is, that's why opposite. Vasodilation decreases blood sugar and dry skin. In case of that particular case, skin will be dry. Sympathetic nervous system stimulates beta 1 that increases heart rate. So in case of neurogenic shock, that will decrease heart rate. So that's why there is decreased blood pressure as well as decreased heart rate. It's okay. So that is the thing why heart rate is low in case of neurogenic shock. So that question is commonly asked or commonly you have to need to write in written examination. So the question may be the how to differentiate SCI if above and below T1. So above T1 results in quadriplegia and below T1 paraplegia. Partial lesion. What indicates partial lesion? It is complete or partial. Partial also differentiated in many times anterior, then brown checkered. Okay, so you have to take history. Start from history that whether there is any sensation of voluntary movement in volumes. Okay, sacral sparing that preserves active flexion. Sacrum is not injured. Active anal squeeze, intact perineal sensation, bulbo-cavernous reflex. So all these things will differentiate a partial SCI from complete spinal cord injury. So if you want ask the telltale sign of neurogenic shock, we will tell that this is bradycardia with hypotension, decreased core temperature, but warm or dry extremity. I think in previous slide I have described why this occurred. Okay. So now the basic and paraclinical sciences, why this occurs. So I think you all know cortical spine, ipsilateral motor, spinothalamic, contralateral pain and temperature. You guys all know. And this prognosis again, level of the fracture, age of the patient, as usual. I have stated in previous question. And complications, you guys all know the complication is the pressure sore, pain, spasticity. They very well mentioned. Autonomic dysreflexia, DVT, very important. So these are the complications. Okay. So the next scenario that is coming 2020. 25 years old, a motorcyclist faced RTA 3 years back. At the site, he was found unconscious, but right now he is well oriented conscious. He is feeling short of breath with bruise marks over left chest with diminished respiratory movement. So that question, that was not the actual question I have mentioned. So history again mechanism, condition prior to injury, condition after it. Okay, so these are the duration. Examination again see ABCD and secondary survey. In trauma mention, keep in mind about a secondary survey, and in secondary survey mention that particular site's examination. Like it is traumatic brain injury, so we will go for the battle site, raccoon's eye. Okay, cranial nerve examination, like mostly the facial nerve and the vestibulocochlear nerve, because they are injured in skull-based fractures. Midbrain or brainstem injury, there will be gaze paresis or this conjugate gaze. Peripheral nerve we have to look for tone, look for power, look for reflexes, look for sensation, and you have to go do parectal examination also. So these are the secondary surveys you need to go for traumatic brain injury also. You have to assess the pupil. Okay, you have to look for the contralateral hemiparesis. So things. Then investigations. The CT scan of brain, chest X and other things. Okay, so I am just going fast now. So explain how chest trauma will modify brain injury. We have guys all know. So the great question may be asked in written. They explain how chest trauma will modify brain injury. Very simple answer. In chest trauma, the patient, due to pain, patient cannot breathe properly. So there will be less respiratory movement. So carbon dioxide cannot get out from our respiratory system. So carbon dioxide will be entrapped. There will be raised partial pressure carbon dioxide. You all know this partial pressure carbon dioxide, that vasodilation is a vasodilator that will dilate the vascular system of the brain. So previously there is this patient is having bleeding from brain. If the vasodilation occurs, the blood will accumulate more and more. So that will endanger, that will uh, act adversely over the traumatic brain injury. So that is important. The chest trauma will hamper the brain trauma. Okay. The question may be asked that why is that CT scan findings? Teacher will ask that why CT scan findings? This question was asked to me also. So you call this a biconvex, okay, or lenticular shape at that particular region, frontal or temporoparietal or frontoparietal, that region. So the teacher may ask that why such shape in CT scan? So you will tell the sir, as draw is not adherent to brain, as it is to the skull, subdural blood is free to expand across the brain surface, giving a diffuse concave appearance. So these are the things may be asked. Some patients, the teacher may ask that this patient has lost his consciousness a few years later. Scenario, again, you can that patient has lost his consciousness a few years later. Now explain this. So you go for the lucid interval. So first of all, sir, patient loses his trauma due to neurogenic shock due to trauma. Then he regained his consciousness. After few hours, the blood will accumulate in the extradural space, that will compress, and patient will lose his consciousness again. So this is lucid interval. Okay. Now that the question may be asked that explain contralateral hemiparesis and ipsilateral dilated pupil in such case. You will describe that exam findings is this. Then teacher may ask, even in written question, it could come. So you guys all know in traumatic brain injury, there is some herniation. Even in short note, you can find a question, herniation syndromes. Okay. Uncus, temporal region, uncal herniation. In uncal, temporal lobe herniating over 10 to heavily, which compresses third nerve. And that compression dilates the pupil. And this is ipsilateral dilation. Right side, if it is the right side, it will dilate right pupil. The uncus also compresses upper brainstem with reticular system, oculomotor nerve, and corticospinal tract. And corticospinal tract decussates. That's why there will be contralateral hemiparesis. Okay. Also, there is subfalcine herniation that will compress ipsilateral anterior cerebral artery. So that will also cause ischemia, and that thing that will contralateral leg weakness. So that question is very important. There are two practical questions. Another thing, explain Cushing's triad. Cushing's triad, we all know that there will be patient hypertension, that will irregular respiration, and bradycardia. Okay, so that Cushing triad, why occurs? Cerebral tonsil, there will be raised intracranial pressure due to accumulated blood, extradural space. It will push downwards due to herniation, and that will push towards the cerebral tonsil. Okay, the tonsillar herniation will compress the brainstem where the vasomotor centers are located, and for that reason, blood pressure and respiration will be changed. That's why this is Cushing triad. So these questions are very important. Now treatment. Treatment is principle of traumatic brain injury management, or how you will decrease the intracranial pressure. And as well as in trauma general management, as like as ATLS protocol, plus you have to manage the chest and other you will look for other acidic injuries. Okay. Then for extradural hematoma, we have to elevate the head end of the bed. We have to loosen the collar to improve the venous drainage. We have to control the seizure and also pyrexia. We have to give barbiturates. We have to give sedative, analgesic, heavy analgesic, muscle relaxant, oxygen ventilation, even mannitol. If there is midline shifting, we have to give mannitol, as well as we have to go for surgery. We need to go for surgery like barhole or craniotomy. Okay, and removal of the clot in the extradural space. Okay, so these are the things. Surgical preparation. Also, that scenario can come out the acute subdural hematoma. In that cases, also similar thing, but the shape of the thing will be shape of the clot will be concavo convex. Okay, and you guys all know the acute subdural hematoma, acute and chronic subdural hematoma, and chronic subdural hematoma. Chronic subdural hematoma usually occurs in aged person more than 65 years. And extradural hematoma is due to middle meningeal artery, arterial bleeding, and chronic subdural hematoma is due to venous bleeding. So these are the things, and we maybe asked about the fluid management. Okay, what type of fluid is given in traumatic brain injury? Then we know hypertonic saline. Okay, even mannitol 20%. Okay, mannitol is very hypertonic. So hypertonic saline is used as fluid management. At a discussion, patient teacher may ask that why. You guys all know it. And discuss use of mannitol, steroid, barbiturates. Okay, so these questions may be asked. Okay, so this is the prognosis and complications. In Bayesian lab, there is uh, a headache, memory, cognitive impairment, and also post-concussive syndrome. Okay, an outcome assessment. There are a few points in Glasgow Outcome Score, and there's some parameters like how to maintain the parameters in case of traumatic brain injury. These parameters are very essential to memorize and very well written in Bayesian law. Okay, there is a question that for something. Then an intubated patient responds to painful stimuli and flexes. Responds to painful stimuli and flexes his arm. Mentioned is GCS score. Okay, so we all know GCS score consists of eye, motor, and verbal. But that patient is intubated, so that patient's verbal response, you guys don't know. He may have verbal response, but due to intubation, he is not responding. Okay, that's why the GCS will be 6T. Okay, 6T. T for intubation. So that should be mentioned. Somehow that can come in your OSP examination also. Now chest trauma, very important. Scenario may be very similar, like chest trauma RTA patient or penetrating trauma patient. That patient may come with features of tension pneumothorax like increasing restlessness with tachypnea, dyspnea, or compressed collapsed or collapsed neck veins, or even that patient may have back striate like tachypnea, central venous pressure is raised, distended neck veins, muffled heart sound. Okay, so that scenario may be this flail chest. Flail chest on a chest X-ray, will find that 3 or more ribs are fractured in 2 or more sides. So that scenario is very easy to produce, and you guys will eventually know, can diagnose that particular thing, disease. Okay, then history, again same thing, examination, again general examination, and we go for the chest examination. That even the chest will be silent, respiratory movement will be affected side restricted, trachea deviated to the opposite side, vocal fremitus will be increased, hyperresonant on auscultation, hyperresonant on percussion, and the decreased or absent bass sound on auscultation. So, classic very easy. Investigation is more easy. So we can go for chest X-ray, and also we can go 3D reconstructed CT scan of the chest for better evaluation of the fracture. And diagnosis, you guys mentioned. You can mention the age, then diagnosis, and also if there are any particular other features associated disease mentioned in your question, you should mention in diagnosis also. Diagnosis, if you elaborately 2 to 3 suspected things, that is very all, and that is also better. Relevant basics, in case of tension pneumothorax, there is tachypnea, hypertension with decreased bass sound, deviation of trachea, and pericardial tamponade. You guys all know. What is the contrast in shock with tamponade? That is distended veins rather than collapse. And in tension pneumothorax, you guys all know the patient dies due to obstructive shock. Okay, how this obstruction occurs? In tension, this works as a one-way valve. So the one-way valve, air only enters, cannot exist. So the interpolar pressure becomes above than atmospheric pressure, and that will shift mediastinum away from the site of injury, opposite side. And there is significant decrease in venous return to heart. So there will be obstruction to the superior vena cava, inferior vena cava. The vena cava obstruction will also compromise the ventilation. That's why patient will die due to obstructive shock. Obstructive shock. Okay. So the teacher may another scenario may be found. There will be open sucking chest wound. Okay, and open sucking chest wound. If the wound is large, the interpleural pressure remains equal to pressure. If we completely close this wound, that will lead to tension pneumothorax. So, in case of open sucking chest wound, eh, we cover it. We keep one part open. That's why to prevent development of tension pneumothorax with offsite or something. So these are another thing. Okay, so there is another scenario. That means 60 years old woman runs her car off and she presents with severe anterior chest pain. BP is 110 by 80 minutes of mercury. Chest X-ray shows widened mediastinum. Okay, and patient is I am just asking. I am just targeting about the questions only. No, I think you guys have known what is the how the teacher will ask questions. Patient is hemodynamically stable. What may be the reason? The reason may be, sir, adventitia is intact. That's why patient is hemodynamically stable. When to suspect aortic disruption? In patients with gross asymmetry in SVP. Okay, gross asymmetry, like in between two upper limbs or between upper and lower limbs. Widened pulse pressure, chest wall contusion. So these are the things. If we find that things, we have to suspect aortic disruption. Commonest site of injury, it is distal to origin of left subclavian vessel, artery, as this vessel is fixed to ligamentum arteriosum. So these are the questions. Okay, this aortic disruption usually doesn't occur singly. It 90% time it is associated with other injury like cerebral, thoracic, intraabdominal, pelvic extremity. And extra findings are widened mediastinum, loss of aortic pulmonary window, widening of left parasternal line. Okay. Other investigation, there is CCT, contrast and CT scan is the investigation choice. Okay. And also you can go transvasal echo. Treatment according to ATLS, and we have to definite treatment as a repair. Repair can be done by open or endovascular technique, either. Okay. And differentials, that may be MI, pulmonary embolism, these things may coexist. And this open and EVAR technique, that complication is paraplegia. This spinal cord is very sensitive to ischemia and nerve tissue and can be damaged by interruption of blood supply. So this patient may suffer from paraplegia after surgery. Okay. Another question may be that 30 years old man presented with history of blunt trauma of abdomen 3 days back. 3 days back. So every information is very important. 3 days back. So again, history is similar. Examination, you guys all know, abdomen examination, general examination, abdomen examination. Okay, so very important. Abdomen investigations, you guys all know, Phoenix abdomen, ultrasound abdomen, even that first, first we go for. And diagnosis, the 30 were male with perforation of the gastrointestinal hollow viscous with history of blunt trauma, these things. And 3 days, this patient is 3 days, that means patient may got some septicemic feature also. So patient teacher may ask relevant basic effect of time lapse and probable cause of time lapse. Effect of time lapse in traumatic perforation. You guys you know that usually blunt trauma abdominal patient usually come later. The patient can suspect, patient ignores that maybe he is not having any danger. In penetrating injury, the patient usually comes within hours. But in blunt trauma, patient comes after days even. I have got a patient coming with 5 to 6 days after trauma. Okay, he was not admitted. He was in his home. And probable cause of time lapse, that patient ignores that thing. Patient suspect that he is not having any problem, or that may be the diagnostic dilemma also. We cannot even diagnose it properly. As we don't suspect any injury, that's why we don't investigate, or that diagnostic dilemma also lead to time lapse in blunt trauma patient. And treatment, you guys, in general treatments and management, laceration in ascending colon, rectum. If ascending colon, we go for repair of that perforation and we will diverse it. We will go for ileostomy, diversion ileostomy. In case of rectal injury, we go for the diversion colostomy. Okay, in jejunal injury, we don't need to. We will just repair it, primary closure it, even in after three days also. Liver, spleen, retroperitoneal hematoma, we have to learn it. Retroperitoneal hematoma, 1 to 3 stage. Liver, everything is graded according to AST. So you have guys need to learn this thing also. Okay. Rationale of the surgery, that teacher may ask that in that particular scenario, they compare diversion versus primary closure in such case. Like this is an old case, 3 days. Patient early age, but if the patient was in more than 70 and the patient has got more 3 days history, the contamination will be more. So in contaminated cases, we need to win over the time. Okay, we don't need to delay the surgery because the patient may not tolerate lots of anesthetic hazards. So the early surgery is recommended and less doing. We will just peritoneal lavage. We will give proper peritoneal lavage. After that, we will not go for primary closure or something, or we will preferably we will go for the diversion. Even we repair something, we repair a gut also. After we will diverse, like we will repair ascending colon injury, and we will diverse ileum as ileostomy. So the contamination, the age of the patient, the duration of the trauma, the timeless, there is an important point for primary closure and diversion. Prognosis, again, progressive factors, age, duration, and grading on the injury, side of the injury, I have discussed, and complications, again, everything. Wound-related complications, Southampton SFC scoring, and anatomical disruption, and residual abscess, these are the complications. And adverse drug reaction, the complication of ileostomy and colostomy, you guys all know what the complication of ileostomy and colostomy. And basic and paraclinical, that patient teacher may ask about electrolyte imbalance in ileostomy and colostomy. You guys all know ileum, if you ileostomy, and there is loss of more electrolytes. In colostomy, there is no loss of electrolytes. So in ileostomy patient, we need to go for serum electrolytes, routine serum electrolytes, but in colostomy, we don't need it. The question may be extremity trauma, open tibia fibula, or supracondylar fracture. In open fracture, we all know that there is a classification, Gastill and Anderson classification, 1, 2, 3, and 3 ABC. Okay, the size of the defect, contamination of the this thing. And in case of in the supracondylar fracture, the compartment syndrome, very important, and this is the favorite question, that how will you, that a 5 years old boy has come to you and you are not finding any pulse, distal pulse. So how will you manage this patient? First of all, we have to immobilize. Okay, so look that the patient has come like here, here, and you are not finding any pulse. So first of all, give traction, counter traction, reduction at this place, and keep a hand over the peripheral pulse and try to reduce or try to mobilize. When you will get feel the pulse immobile at that particular place, you need not to go for long arm back slap or something other technique. At that side, you find, but you feel the pulse, radial pulse, immobile at that particular area. So compartments in supracondylar fracture is very important because that will that can injure brachial artery, will lead to compartment syndrome, and if not treated properly, it may lead to Bachmann ischemic contracture. So that thing is also very important. So in fracture, that's simple things. A compartment syndrome, if you release delayedly, that will lead to ischemic reperfusion injury. So delayed, if we delay in identifying, that will lead to ischemic, that is also dangerous, like fatal. And also prognosis complication, again theme, like complications, general complications, specific, immediate, that means injury to adjacent neurovascular structure I have described. and delayed long bones like malunion, delayed union, non-union, osteoarthritis, much resource weakness. So these are the things in case of trauma. Okay, extremity trauma. So further reading for my things that blast injuries. Okay, disaster chapter, blast injury, blast lung, that primary, second, tertiary, coronary, quaternary. There are lots of gunshot, principle of gunshot. Okay, previously the question came that a gunshot wound over the right groin. So its entry point is velocity, its exit point. Okay, at what location it was shooted, what was the condition of the shooter. So lots of things we will describe this gunshot wound, maxillofacial trauma, like how to place the patient. There is a picture given in Balian Lab. That question was asked in Viva also. Yeah. How to place a patient in maxillofacial trauma, parotid duct disruption management. So these are questions you need to take proper preparation. So I think I tried to discuss the interactive walls examinations for trauma patients, which is I think covered the written examination also. We can 2, 3, 4 questions to my that was my suggestions, my suggestions for you guys, as I am not very much good in English, but I tried to deliver it in English. I don't know how was this, but I tried. Okay, so pardon my mistakes, and thank you very much for watching.